I live in Chicago. Half of my life is spent trying to stay warm and dreaming of being on the beach. And the other half is just dreading when the next winter comes. I might have a problem with thermoregulation. But in all seriousness, thermoregulation is a major concept. We are humans who need to maintain homeostasis in our temperature monitoring and maintaining a good temperature. And in Chicago, that can be really hard to do with super hot summers and really, really cold, really bitter cold winters. And so today we're going to be talking about this concept of thermoregulation and everything that's involved in that. We'll be in your Giddens, chapter 10 for this lecture. And we're going to use our concept guides to help us with these objectives. So go ahead and pause your screen here, read through the objectives so you're prepared to answer these as you go through the training. First, we're going to go ahead and define and describe the concept of thermoregulation. Thermoregulation is the process of maintaining the body's core temperature at a near constant value. We don't want to be too hot, we don't want to be too cold, and our bodies are human thermostats that are constantly helping to regulate that for us. Now, here are some key terms that you'll need to know that we talk a lot about in healthcare. Normothermia means the normal body temperature, and it ranges between 36.5 and 37.2 Celsius. Hypothermia is a body temperature below 36.2 Celsius, and hyper means high, an elevated body temperature above 37.6 Celsius. So hypo, low, hyper, high. And hyperpyrexia is when you have an extremely high body temperature above 41.5 degrees Celsius. And a fever is defined as an elevation in body temperature that's due to a change in the set point of our body, and it's usually from an infection. Not always, but mostly. So the scope or the range for thermoregulation ranges from well below normal to well behind normal, and both of those extremes have their dangers. So we can have anything from severe hypothermia to severe hyperpyrexia, and we want to really end up in that normothermic area right in the middle, right about 36.2 to 37.6 Celsius. So I was joking a little at the beginning of this video, but it's true. I'm always cold, and I'm always looking for a space heater or a fire or extra blankets. And so in our house, we have this fight over the thermostat. I turn it up and my husband turns it down, and it just keeps going. And there's this war in our house of the turning up and down the thermostat to maintain what would be, normal temperature for our house. And in our body, that thermostat is the hypothalamus. It's a part of our brain that regulates temperature control, and it can use different feedback to make us colder or hotter and to help regulate that. And so when we need to increase our temperature, blood vessels are going to dilate, we're going to get flushed, and sweat glands become more active. And when we have a decreased temperature, blood vessels are going to constrict, and heat is trapped deep in the tissues. And sweat glands are becoming less active, and the skeletal muscles contract, causing shivering. And so those mechanisms are what our hypothalamus uses to help regulate our temperature if we get too hot, to help cool us down, and if we get too cold, to help warm us up. So we've got these really cool mechanisms in our body that help us to maintain a normal temperature. So in terms of variation in context, we have the concept of fever. A fever is often caused by the endotoxins and the exotoxins of bacteria being released and causing an increase in the set point of our hypothalamus. Hyperthermia means really, really hot, high temperature. Hypothermia means really little low, low temperature. Hyper, high, hypo, low. Okay, so what are the consequences of thermoregulation? So it really depends on the severity and the duration of exposure. So if we take my kids out sledding and I come home and my fingers are really cold, and my nose is really cold, and I'm shivering, I might just need a little cup of coffee to help me warm up, maybe sit by the fire and just, get toasty, put an extra blanket on. And that would be just fine for the amount of severity and the duration of the exposure. But, eventually, if left unchecked, a little bit of shivering and a little bit of vasoconstriction, blood vessels tightening up, is not going to work for us, and the body decompensates and eventually vasodilates, where those blood vessels constrict, and there's this accelerated loss of body heat where the body just gives up and it can't do it anymore. And so we want to catch things like hypothermia early so we can intervene early before things get out of hand. And I think that's the name of the game in most things in nursing, is early assessment and identification of problems so that we can intervene early before things get out of hand. So let's take a look at the risk factors that individuals are at risk for thermoregulation problems. So first of all, let's talk about populations at risk. Really, all individuals, regardless of age, gender, or race, are potentially at risk. But in general, as you'll see in many things we talk about in terms of risks, the very young and the very old tend to be at higher risk. And it has to do with the fact that they don't have as many compensatory mechanisms. They don't have as much residual fat and reserves. We can also see poor people who are going to be at more risk. And we see this all the time in the ER in the winters. The undomiciled, also known as homeless, people come in with frostbite and hypothermia because they just don't have good access to staying warm. And consequently, in the summers, we have to open up cooling centers for our undomiciled people, and even people who just don't have good air conditioning in their house, to make sure that because they can be at risk for problems with hyperthermia in the summer. You'll see on the news all the time, Chicago will say, make sure you go check on your neighbors this week. It's going to be a heat wave. Make sure your elderly neighbors are cool and that they're staying safe. And then, of course, people who live naturally in very hot and cold climates are also going to be at risk due to the nature of the environment they live in. So how do we recognize when an individual has problems with thermoregulation? Here's what we're going to find on exam for someone who's hyperthermia, very high temperature. So we're going to see an elevated temperature when we take their temperature. Their skin is going to be flushed, meaning kind of hot and warm and pink. They could be sweaty, very diaphoretic, meaning very sweaty, or they can just have no sweat at all, which you'd be like, that's weird because you should be really hot and sweaty, but their body just kind of quits and gives up. They could have dry mucous membranes. So one way you can assess this is just have them stick out their tongue, and the inside of their mouth, inside of their cheeks, and all inside of their lips, and everything should be nice and wet. They can have decreased urinary output. So their urine becomes very concentrated, very dark, and they're not urinating as often. You're going to look for signs and symptoms of dehydration and things like electrolyte imbalances on lab exams. And ultimately, if left unchecked and to an extreme level, patients can have seizures. Electrolyte imbalances can lead to cardiac arrhythmias, heart dysregulation, seizures, and altered mental status. And then on the flip side, for hypothermia, low body temperature, we're going to see them have a low temperature. And in fact, if it's really a person who's really hypothermic, we're going to take a rectal temp to get a good core temperature. And people who are very, very low, we actually have to use special thermometers that go low enough to read what their body temperature is. Now, keep in mind, their skin can be cool to the touch. They can have a slow capillary refill. So you see how I push? See how it blanches right away? It turns white. But as soon as I let go, how quickly it pinks up again. So that's called capillary refill. And you want your capillary refill to be 2 seconds or less. That's called a brisk cap refill. And so patients who have poor circulation to their fingers, because everything's clamped down and cold, they're not going to have a brisk cap refill. It's going to go back much slower. Their skin could be pale or cyanotic, meaning bluish. They could be having shivering and muscle rigidity. I feel like I live half of my winter shivering and in muscle rigidity. I just hate the cold. They can also have altered mental status changes. They can have cardiac dysrhythmias. And they can have a complete body system breakdown to the low perfusion, poor blood flow to their vital organs. And this can result in things like low urinary output, where their kidneys are shutting down, a coma, where their brain is shutting down, and cardiovascular collapse. Now, interestingly, you can't be cold and dead. You have to be warm and dead. So when we have people who like fall into Lake Michigan in the winter and they come in and their core temperature is 84 degrees Fahrenheit, we have to warm them up and before we can really pronounce them dead, and hopefully not pronounce them dead, because your body system just shuts down so much when you get that cold that your body doesn't need a lot of oxygen demand. And so you have to warm these patients up to see if their brain starts waking up, to see if their heart starts waking up as they go. So that's not on the test, but just so you know, you can't be cold and dead. You got to be warm and dead to be pronounced. Kind of an interesting ER little thing there. Okay, maybe it's weird. It's okay. I'm an ER nurse. I'm a little weird. What do we need to do to provide nursing and collaborative interventions to optimize thermoregulation? So again, primary prevention, we want to prevent this from happening in the first place. So avoid exposure to temperature extremes, maintain the optimal ambient temperature in the home, and that means cooling it in the summer and warming it in the winter. We want to teach our patients not to use their stoves as sources of heat that can cause a lot of carbon monoxide poisoning and danger in that way. We want to teach our patients to dress appropriately for the temperature and to resource them with the needed coats, hats, gloves if they don't have those things. And then making sure that patients are engaging in physical activity appropriate to the temperature conditions. I used to have a lot of friends in the ER who would volunteer at the Chicago Marathon every October. And there would be those really hot years where it'd be like 80 degrees. And my friend was the medical director of the mile 25 medical tent, the last medical tent on the route. And they would just anticipate people kind of dropping and some people actually coding and dying because the temperature for that level of a race at 80 degrees was really dangerous and some people would have problems with it. So we want to make sure that the physical activities are appropriate for the temperature conditions. Okay, some other collaborative interventions that we can discuss. We want to discuss what the underlying cause is. So we need to treat the underlying cause. Is it that they were just outside and they were exposed to the environment, or like what is it that's making them hyperthermic? Do they have a fever and do they have some infection going on? What is it that's causing a dysregulation in their temperature? And then remember that the overall goal is to bring that body temperature into the normal range before any long-term effects occur. Go ahead and take a look with me on page 89 of your Giddens for those clinical nursing skills for thermoregulation. So let's take a look at this clinical nursing skills for thermoregulation on page 89 of Giddens. You're going to do your assessment, and especially things like taking a good temperature and deciding if you need a good rectal temperature, like to get a good core temperature, or what kind is appropriate. You're going to monitor the vital signs, temperature, heart rate, respiratory rate, blood pressure. You may need external warming devices. We have things like Bear Hugger, which are so nice. It's these disposable blankets that you hook up to this hot air source, and it blows hot air through this blanket to keep the patient warm. Or we even have fluid warmers where the IV fluids go into this warming device before going into the patient to warm them kind of from the inside out. We can also do warm fluid lavage, where we even like put warm fluids down into their stomach cavity and give them heated, humidified oxygen. Or we can cool them off with things like cold water baths or cool IV fluids that are from the refrigerator. Again, cool lavage, meaning putting water into their stomach and bringing it back out so that we're cooling them from their core, or even cooling blankets. So either extreme, we have these interventions we can do to warm patients up or cool them down as needed. So if you have a patient who's too hot, they're hyperthermic, get those extra cold clothes and blankets off of them. Provide external cool packs, especially to areas that are more vascular, to the groin, the axilla, that's the armpit, to the neck. Those areas are going to help cool the patient down quicker. Provide a cooling blanket if it's available. Hydrate with cool fluids, either oral if they're able to drink, or an IV. We can leave some IV fluids in the refrigerator sometimes. We can lavage them internally with cool fluids, and we can also administer antipyretic drug therapy. Things like Tylenol, ibuprofen, those are going to help reduce the fever that's causing hyperthermia, if a fever is the cause of the hyperthermia to begin with. Now, for hypothermia, we need to get them out of the cold. We need to start warming them up. We need to warm them up slowly, because if you warm them up too quickly, there can be shifts in their electrolytes that can cause severe dysrhythmias, cardiac dysrhythmias, and even death. So we warm them up slowly using both external and internal warming measures. And we always are monitoring them carefully as we do this. Interrelated concepts, intracranial regulation. It's not uncommon that a patients, who are just totally overdosing on heroin, or they've just had a big binge and on alcohol, that they go pass out in the snow, and then they're in trouble and they have thermoregulation problems, not because they would have to begin with, but because they had an intracranial regulation problem where they passed out from this overdose that now has caused a thermoregulation problem. Fluids and electrolytes can definitely shift if there's changes in thermoregulation, so we need to be aware of our patients' electrolytes and warming them or cooling them carefully. Impaired tissue integrity, things like frostbite, sunburn, can all be caused by dysregulation. Perfusion, you know how our fingers get cold and the tips of our nose get cold in the winter? That's because we're getting poor perfusion, poor blood flow to those areas. And so thermoregulation can cause changes in perfusion. And then infection and thermoregulation go hand in hand, because infection with those bacteria releasing the endo and exotoxins can cause a change in the set point of your temperature, causing a fever. Fever is thermodysregulation, hyperthermia. So here are some exemplars from your text. The one I'd want you to focus on most acutely for the purpose of today would be fever and environmental exposure, hypothermia. Go ahead and read through the other ones. Heat stroke's good too, but just to kind of get an idea of the types of illnesses and injuries that are associated with thermoregulation. So as the temperature gets colder and you start dreaming about next summer and going to the beach, and you're sitting in your house trying to stay warm with all your extra layers on, keep in mind that what you're practicing is thermoregulation, helping yourself to stay normothermic and dreaming of the next time it's summer. See you next time.